Hello, everyone, and welcome to Research Ride, a 30-minute journey from idea to implementation of research programs in the Department of Medicine at Emory University. I am your ride leader, Charlie Searles, and I'm a faculty member in the Division of Cardiology and the Associate Vice Chair for Research in the Department of Medicine. Today we'll be touring with Dr. Ted Johnson, who came into the studio with his bike helmet and gloves. Dr. Johnson is a professor of medicine and family and preventive medicine. He's also chair of the Family and Preventive Medicine Department, and he's the division director for general internal medicine. He leads the Georgia GEAR program, which is a geriatric workforce enhancement program. He also has secondary appointments in the Department of Urology, the Department of Epidemiology, and the School of Nursing. Thank you very much, Ted, for coming to join us today for this research ride.
Thanks, Charlie.
Did I miss anything there?
No, I've done a lot of things and I've handed a lot of things off. It doesn't look like I have, but I have.
Could you start with telling us about your research and the other work that you do at Emory?
Yeah, I came here in 1997, so this is the longest I've ever held a job. So I figured this would be a 7-year stint, and it just kept getting better and better and better. So I originally came here to work for then division director in geriatric medicine and gerontology, Joe Auslander. So he had come here from UCLA in 1996, and so I was very interested in aging. And I've always been interested in aging. And so as I think about preventive medicine and family medicine and primary care and geriatrics, I think about, what would it take to build a health system and a care network that would actually work for people as they age. And I think that, not perfectly, but I think that if we do things that work for aging older adults, then we actually have developed a system that seems to work for everybody. So that's been kind of a unifying concept since I've been here. I've been honored to work at the Atlanta VA health system. I started there as a full-time employee in 1997. I came over to work at Emory as the division director for geriatric medicine and gerontology in 2008 when Joe Auslander left and went to Florida Atlantic University. I've been clinically active all throughout my career. I've had administrative leadership roles ever since I came here. And you alluded to this earlier. I've tried to, branch out, reach across the aisle, do work with nurses, do work with neurologists, do work with kidney docs, infectious disease docs. And so, Emory says that they're a collaborative place, and I really believe that, and I've seen that. And so that's been great.
That is incredibly interesting about the way that you have branched out and been able to integrate your work with others at Emory. By the way, for my listeners, Joe Auslander is one of the leading figures in geriatrics and gerontology. Ted, can you tell us how you got into research?
So probably my interest in research was most self-evident to me as a third-year medical student when I was at Northwestern, and I was learning about deep vein thrombosis, and we had a patient come in with deep vein thrombosis, and in that era, you got a week of bed rest, a week of intravenous heparin, and then an additional week in the hospital on Coumadin, and then you were discharged 14 days later. And I was like, I thought that stasis was bad for thrombosis. And so why are we putting these people in bed for 7 days, and then keeping them for another 7 days? And then my attending would try and explain it. I said, that really doesn't make any sense. And he said, okay, well, you can grow up and you can figure out why that's the wrong way to do it and go ahead and then, get back in touch with me. So there was some element of just like stop asking so many questions that he was doing with me. And then there was some element of we don't know why we're doing things that way. And so that was the beginning of kind of my interest in research. And then during my chief resident year when I was at Chapel Hill in internal medicine, I was trying to figure out, how could residents have less of an interrupted experience when they're trainees. And so I tried to do a study and I figured out that I really didn't know any research tools. And so with that, I did some fellowships. I did a postdoctoral fellowship. I did an MPH in epidemiology. I realized I needed to go somewhere and be with someone who actually knew and understood how to do research. And so that was how I ended up coming to Emory, just to figure out how to do research. I mentioned Joe Auslander. He, at the time, was doing clinical trials in older adults with urinary incontinence, mostly in the long-term care setting. And so I asked him, I'd be interested in coming to work with you. We went through a couple of things, found a good position over at the VA. And the interesting thing was, as any good mentor would do, he's like, you don't need to do what I just did. You need to figure out kind of what's that next thing. What's the next thing that's coming along? And I think that that's what a really good mentor does, as well as read everything that you write and mark it up and tell you to try again. But one of the things that a great mentor does is, like, if you're going to spend a lot of time, try this question, try these tools, try this topic. And so if someone read most of my papers, they're about peeing at night, which is very popular among the 80-plus set. I mean, you could talk about, I spend a lot of time doing research on peeing at night, and people in their 30s are like, yeah, that's really good. What does your wife do? Because I don't want to hear anything more about peeing at night. But if you talk to your parents or your grandparents or your uncle, they're like, oh, yeah, we should talk about that. That's a problem for me.
So you're referring to nocturia, peeing at night.
It's a symptom, and even in the literature about nocturia, there's a lot of discussion about, well, the urologists don't really think it's theirs, the primary care doctor don't think it's their problem, the sleep doctors don't think it's their problem. So it is one of those areas where you kind of can bring collaborative teams together to actually solve each part of this. So there's some interesting things. People who get up at night actually are more likely to fall. And are they more likely to fall because they're sleep deprived? Are they more likely to fall because they're ambulating at night? If older adults have accidental falls, are daytime falls different than nighttime falls? And so you end up in a lot of areas to figure out, kind of how does this work? It used to be that when you're thinking about lower urinary tract symptoms, that you'd try just watching and seeing if it went away. And if that didn't work, you'd try some medicine. And if medicine didn't work, you'd try some surgery. It turns out that peeing at night's not really treated very well by surgery. And so that was another thing that, after my boss told me you should do this, I thought about it, and I was like, well, there's some interesting things about this symptom, that people get a lot of treatments that actually don't work. And sometimes people actually have obstructive sleep apnea, and they're getting their prostate taken care of under a surgical procedure. And so that's one of those things that appeals to me, of let's not give people ineffective treatments. It goes all the way back to, waiting 14 days in the hospital because you had a blood clot in your leg. We don't do anything remotely near that today.
So earlier in your career, you recognized that nocturia was a problem that was more common than was being reported, and that there was issues with the way it was being addressed. So that's what led you to study it further.
Yeah, I mean, in addition to my mentor saying this would be a great idea for you, there's just, it turns out that peeing at night is really bothersome the more often that you have it. But two different people can go to the bathroom 3 times at night and have very different experiences and ratings of that. And it turns out that that has to do with sleep factors, not surprisingly. But it turns out that the more difficulty you have getting back to sleep, or the more fatigued that you are in the morning, the more that this is a problem. At a far extreme, one person that we did a qualitative research study, and he was one of our participants, he said, I get up 5 times a night, and the interviewer said, that must be awful. He said, no, actually, I enjoy smoking at night, so it's just another opportunity to get a cig. And so outside of that, the more often you get up, the more bothersome it is. And for older adults versus younger people, there are two additional things. If you have nocturia, it makes you feel older, because somehow, even if you hadn't heard about this when you were 30, you start talking to all your older friends, and they're like, oh yeah, I do that too. That comes with aging. And the other thing that happens in older adults that doesn't happen in younger adults is that fear of falling, the nighttime ambulation. So in thinking about this as a problem solver, do you send somebody to an ineffective surgery, or do you actually give them a handheld bedside urinal? Do you, do behavioral interventions to strengthen their pelvic floor muscles and maybe give them some treatments that help them go back to sleep easily? Or do you give them medicines for 10 years? And so I've always tried to figure out what's that easier, safer way to provide effective care.
So these are the issues that you are investigating, or that you have investigated through your 23 years of research experience.
Yeah, and I think that, some of the things that people would say in this community of people who care about lower urinary tract symptoms that our team has done have to do with identifying, how good medications are, how safe medications are, how behavioral interventions and exercise interventions that most people think about are related to women's bladder problems can actually be adapted for men. That's kind of the space that I've been pleased to be part of a team that's contributed a lot to the literature and the science.
And I understand that this work is ongoing.
Yeah.
And you are currently involved in a project that is looking at behavioral and pharmacologic interventions for people who pee at night.
Yep.
And have sleep disturbances.
Yep. And so just like any good team, we had some great pilot results from a VA merit that was funded to me through Rehabilitation Research and Development. And now Camille Vaughn is leading a team of investigators across the country that is looking to combine cognitive behavioral therapy for sleep with exercise-based Kegel exercises for the bladder. So this notion that, are we really treating a bladder problem or are we really treating a sleep problem? And the answer is yes. We're actually trying to treat both. And as you can imagine, I've just explained that some of the medications that people might receive for peeing at night are not so hot. And you can imagine the same thing with giving older adults sleeping medications. That's not a very effective strategy. So how can we actually safely deal with something that people who are older say, this bothers me, this is important to me?
That's very important because the proportion of geriatric patients is growing. And so this problem is becoming more common. But what is interesting to me as a non-geriatric clinician and someone who prescribes medicines for nocturia is that I should be thinking more broadly, that there might be other things that are causing this symptom.
Yeah, I think so. And I think that internists and urologists are failing to consider when there's an obvious sleep dysfunction and problem. Obstructive sleep apnea always comes out in the reviews as CPAP and positive pressure ventilation at night, never comes out as a strong evidence of being useful for nocturia. And that's largely because what's your randomized control trial? Do you prove that people have obstructive sleep apnea and don't treat them and see what happens if they're not treated for this condition that we understand has a lot of detrimental effects? And so there are multiple case series that show that, hey, this CPAP really is awesome for getting rid of bladder symptoms. And that's not how people think about it. Now, not everybody who goes on CPAP ends up getting rid of all of their nighttime voiding, but it's better than any other drug that's out there. You find the right patient, you give them the right treatment.
You mentioned that you got into this particular field based on the advice of your mentor, and you yourself have been a very successful mentor. Talk about your different mentoring approaches and how you mentor people in different ways.
Yeah, thanks for that. I'm really proud of the work that I do there, and I've got some folks that I've been so pleased to be able to work with, and there's some thought that there's this mentor-mentee, and that it's a hierarchical relationship. And in my experience, yeah, I have more in experience, and I have some advice that might fit. But I'm also really listening for what people are saying that they're needing and trying to be as responsive as I can to that. So Camille Vaughn is a hugely successful faculty member here at Emory. She's the division director for geriatrics and gerontology. And so we began working together a long time ago, and I've published more with Camille than I've published with anybody else. And Camille told me one time that she had this talk that's like, and the title of the talk was Managing Your Mentor, which I love that. And I know that some people might take offense to that, but she was like, really what I mean by managing your mentor, at least as I understood her talk, was, just setting up the mentor-mentee relationship so that it's effective and time efficient and targeted and humanistic. I think in a lot of my meetings, if they're an hour or 45 minutes, we spend about 10 minutes talking about what happened to you this weekend, what's going on with your son, how's things. I know that something's gone wrong with your mom. How's your mom doing? And I think that just provides just kind of a humanistic underpinning construct to that. And so if I think that I have advice that I'd love to put on the podcast today, it's don't worry about that first 5 minutes that you spend just really checking in. And I got a note yesterday from somebody that I meet with twice a month who's going through some tough stuff with her family. And she wrote me an email today, said, just that was so meaningful that we spent time talking about that.
I have to say that I've heard that sentiment from your other mentees. I reached out to Melissa Stevens one Saturday morning, and her response was that if you want to talk about Ted Johnson, I can talk to you anytime because that's what he would do. I'm thinking of other stories that I've heard about your mentoring, and the Equipped story comes up.
This is one of those things that you could look at it today and say, this was everybody mentoring everybody else in this. But I had an assignment as a geriatrics leader with the National Strategic Plan on Geriatric Pharmacy and making sure that people were on the right medicines and stuff like that. And so one of the 15 different things that we were talking about was, good prescribing in the emergency room. And then Melissa Stevens had this idea for FAME grant.
Wait, can we just stop 1 second? So the FAME grant is for faculty who do not have a research program but are interested in starting a research program.
Yeah. And so Melissa Stevens is an embedded internist in the emergency department at the Atlanta VA. It's kind of like, why are we putting all these people on these medications when folks come in with acute problems that we know are bad for them? And Camille Vaughn is kind of like, we should really be looking at this Beers criteria thing about bad medications. And through national collaborations, I believe that the Equip study is in, 20 to 30 different locations across the country. And it's just...
I chatted with Camille yesterday. Yeah. I think she said 20.
Crazy, right? I mean, this was a FAME grant, right? A FAME grant that started this work. And then anything that I've ever taken to either of those women has just gotten multiplied times 10 because they're brilliant and really industrious.
So I understand that I agree with what you say there, but I understand that you are being nominated for an award by the American Women's Medical Association.
AMWA.
And I think this speaks to some of the mentoring that you do, or that some of your success has been particularly helping women in medicine or underrepresented people in medicine.
Yeah.
Where's the why for that?
The why is because it's strategic in kind. And the strategic part is that there are so many super talented people that have been perhaps overlooked and not felt as, ready for leadership or ready for success in research or the like. And they're just super talented and super good and very dedicated. And, not to say that men are this way and women are this way, but to say that they're frankly overlooked in certain situations. And so with people who are underrepresented in medicine, I would say the same thing. We're in Atlanta, and this is a place where people want to come. And if we just even make the playing field level, it's a great chance for people to just say, I want to go there. And I think that for making it better than level, making it equitable, I think that just gives us a chance to, do better and better and better. I work in geriatrics, 70% women in geriatrics. I work in primary care, about 68% women in geriatrics, in primary care rather. Down at Grady in general internal medicine, 28% of our group is underrepresented in medicine. Family medicine, similarly. So I just think that if you can build a place that feels fair, looks fair, that talks about fairness and talks about everybody having success, then I think that people get that and see that and want to be a part of it. And so a number of people that have been very kind to me and that I've been very kind to and have let them kind of, soar, put together a letter to a national association to just have some recognition. So it's just a real honor.
So you have talked about your childhood and your upbringing, and I was hoping you could share some of that information with us today.
Yeah, sure. It's interesting because the obvious thing that I could have written about in a college essay was my experience with my parents, who both had profound physical impairments. My dad had polio when he was 4, spent 14 years in a Shriners Hospital for crippled children, came out, went to college, went to grad school, very successful. My mom, likely her mother had German measles, so my mom was born with only one arm. She had a complete right arm and a left arm that stopped just below the elbow. She had unilateral hearing loss and really kind of bad vision. And so, my experience with my parents was that, they were fabulous parents, first of all. But I think from the outside, people would say, there's something really different about these people. And, my parents applied to adopt a child. I have an older half-sister and a younger half-sister, but, they're 30 years apart from each other. So a lot of my childhood was by myself. My parents wanted to adopt. They were told that they were unfit to be parents by the state and not eligible to adopt a child. Before the Americans with Disabilities Act, my dad couldn't actually find a toilet that he could sit on at work. And so if he had to have a bowel movement at work, he would have to drive 25 miles home and the like. And there were just other things that happened to my parents that part of what I internalized was, sure, their resilience. And I think that sometimes there's just no choice. You've got to be resilient. There's not a choice to not be resilient. And I think that part of what I came away from that is that one of my missions is to make sure that people have the ability to fully participate in life and community. And I think that because of, factors that were not in my parents' control, they didn't have the ability to fully participate in community. And so that's not actually a different story from my research, because my research is, thinking about bladder conditions broadly. Bladder conditions are something that keep people at home. They keep people from going out. They keep people from going to church. If you have nocturia, you don't go on the church overnight. You don't go camping. You don't go on a cruise with a friend because they're like, this is going to be bothersome to them. And so I think that this notion of, making sure that people can fully participate in life and community actually resonates with every paper that I write, with every grant that I write, with every project that we consider. And I think that, as a Research Ride podcast message, I think, finding something that matters is really one of those keys.
So just going back to your childhood for 1 minute, as the able-bodied son of 2 disabled parents, is this why you went into medicine?
No. What I really wanted to do was to go in and teach in high school, and my high school teacher said, you should not do that. It's a horrible profession at a horrible time. And I think that I would have enjoyed being a high school teacher, but I think that I was very interested in questions. I was interested in being challenged. I was interested in lifelong learning. I was interested in being of service. And so I think it checked a lot of boxes. I was going to drop out of medical school after the first year, and so and I didn't. And so that was great that I didn't. The thing that brought me back was I was in charge of orientation week for the next year's first years, and so I thought it would be really awkward to not show up. You're going to do great in medical school, but I just can't be there with you. And so it's kind of funny. There is some point where it seems really difficult and it seems really dark, and it seems that it's time to quit, and then it's not always time to quit.
So your approach to how you do your job is what is formed or shaped by your experiences growing up
Yep.
and so forth.
Yep.
But really the job itself was something else that you could be a high school teacher now, or you could be and you would be taking care of vulnerable people.
Yeah, no, I do think that that's true, and I think that there's, I think that one of the things about, I was a little flippant about, why I stayed in medical school, but one of the reasons I stayed in medical school was I realized that it wasn't my parents telling me to do this. I'm the first physician in my family and second generation college grad, and so I think that was the own it moment. It's like no one got me in this position at this medical school other than my intending to do it. And so it was just kind of it's going to be hard and you might as well own it.
That's good advice.
Yeah, no, I think it was hard to come by, and hearing it may not do much for other people, but it may be something that's resonant for people. So I do want to say one more thing about my parents, and that is that for all the things that my parents went through, aging was incredibly difficult for them.
Yeah.
So, and I think that, that was perhaps a little surprising to me, that in the midst of all these physical impairments that they had, you add on the aging process to that. That just made it really difficult. And so it was a challenging personal and professional event.
Well, so that shaped the geriatrics part of this, right?
Absolutely. My mom told me when I was going to medical school, she was maybe about 50 or so, and she said, I really don't need geriatrics. I need plastic surgery. And so what I'd really like you to do is focus on something that matters. And then later, when she was 80, it turned out to be handy knowledge.
I wanted to ask about the beagles.
Yes.
As another vulnerable population,
yes,
does that fit here?
Yeah. So there are two stories about beagles that are worthwhile. One is that our childhood, my daughter Bridget, her childhood dog had a back injury and became incontinent, and so we had an incontinent dog for 8 years, and so not only was that a challenge in dealing with it, but it was not so hot for the dog either. But we made it through that, and she survived with a chronic condition, and it taught us a lot about a lot of things. My wife, Susan, had signed up to be in Beagle Rescue, and we rescued 10 unadoptable beagles over the course of 2 or 3 years when we were down there living in Decatur.
These weren't beagles that were part of medical experiments.
No, they were not. They were not. They were like fat beagles and mixed beagles and beagles that wouldn't walk. That beagle don't walk. Yeah, and so we tried to rehabilitate those other dogs in our old incontinent dog. Helped us with that. And then one final story is that we adopted a dog that we love that is at home right now. Her name is Molly the Collie, and she's a pandemic dog. And we did a little cheek swab of Molly the Collie. She is 0% collie. There is no.
Oh, is that right?
Yeah, great marketing, Molly the Collie.
Where did you adopt her from?
Up at a kill shelter.
Oh,
yeah, right. And so no one adopts 10-year-old dogs except geriatricians and loving wives. And so it turns out that this dog is a beagle.
So you take care of geriatric species of all species.
I do.
It doesn't matter what your species is. It's
yeah. Come on down.
equal opportunity.
Exactly. We got old dogs. We got old cats. Everything's old.
So on Research Ride podcasts, we like to get the full picture of our writers. And so can you talk about what you do outside of work?
Right. So I do some cycling. I am that urban cyclist. I will find a way to do anywhere between a 1 mile to 9 mile ride doing errands. And I was one of the early cyclists and used to bike up the hill from Wesley Woods Center down at the bottom of the hill. Bike up Clifton Road to go to meeting. I live on the Beltline, so I go out and about and walking everywhere. Southern California kid, I did go out and buy an electric skateboard. I know it's bad, but I do some stuff with that. And I also am a paddleboarder.
Oh, nice. Where do you paddleboard?
Up at Lake Lanier. Yeah, it's really...
So you go regularly to paddleboard?
It was nice when no one could figure out what they could do. You could paddleboard.
You can paddleboard.
Right.
So do you ride to Grady?
I could, but I don't. I compost at Grady. So my car is full of all of our scraps that we throw in the freezer, and Grady has a compost. I know that Carlos Del Rio would be okay with it. I know that he doesn't want people bringing their liquor bottles down there. That's bad.
Yeah.
But I do compost down at Grady so I don't ride my bike. A lot of compost.
So you're helping the vulnerable planet there.
Yeah, that's right. It's all tied in together.
It's all tied in together. And one of the themes that's come out when in talking to your mentees, I talked to two mentees. I talked to Camille and I talked to Melissa.
Good choices. They're awesome folks.
Because I have their numbers.
Perfect. It's a little VA connection. The VA's been a great place for the department, a great place for faculty. So, yeah.
There's, a huge VA connection there.
That's right.
I don't think I would have known Melissa otherwise.
Right.
So, one of the themes that comes out is that you amplify people. And I guess that's manifested in many ways. But I wanted to ask about one particular way.
Okay.
Twitter.
Yeah.
How did you get into Twitter, and why do you tweet?
Yeah. So my Twitter handle is @baldheadted, which is something that my
hashtag.
Yeah, hashtag geriatrics, hashtag aging. Baldhead Ted was something that one of my daughter's soccer teammates called me. I went to pick her up and she's like, "Hey, Baldhead Ted." And I was like, "That's good."
Should I be angry or?
No, it's perfect. So @baldhead Ted, yeah. And so I do try and talk about other people, right here and now. It's a half hour of talking, but I still want to talk about other people, and I think that I use Twitter to talk about what's going well with folks that are part of our team and people that I care about.
Yeah, I mean, you almost universally. I went through some of your Twitter feed, and you're amplifying or announcing successes of others that is really amazing. So as we come to the end of our ride, there are a few questions that we like to ask all of our riders. And the first question is, what is the one thing you did early in your career that you would advise other people to do?
Very early on in my career, I worked with Joe Auslander and Joe Hardison. Both of those people I want to give a shout out to. With Joe Hardison was my clinical boss, gave me some great advice. And during my first year, he's like, "Don't do that." And then he'd tell me, "Yeah, do more of that, do less of that." With Joe Auslander, he and I had an email code that was just basically opportunity or distraction, ? You get presented with a lot of things coming your way as a junior faculty member, and especially when you work with a very talented mentor who can't do everything that he's asked to do. And so I would always ask, somebody asked me to do this. Is this an opportunity or a distraction? And I'd be right. I'd be right in terms of what he would say about 65% of the time. But sometimes you come back and say, this may not seem so good on the surface, but the person who's asking you is a person who'd be great to get to know. And so I think that one of those pieces of advice is find somebody who cares about you, who can give you some advice because they know the question or they know the ropes. And just be able to have a quick, is this an opportunity or distraction? And get some advice about, do more of that, do less of that.
Able to see the big picture.
Absolutely. Joe Auslander, when he came up and visited me when I was in my postdoc at UNC Chapel Hill, took a look at a national survey that I was looking at, and I told him I wanted to do this associated factors with. He's like, "That's a boring paper. It's been done about 10 times. Let me see your questionnaire." He's like, "Self-rated health status, that's a really good question. Not many data sets have that." And so it was my master's thesis when I was at Chapel Hill. He told me what was the question to ask. I got it published in a journal that he worked for, and it's been well cited. So, I mean, as a first early paper, it's really good to not spend 2 years doing something that when you're all done, no one wants to see it.
So on the flip side of that, what is one thing that you would have done differently in your research career? Now that you are looking back on 23 years of work.
So something that I did that I wouldn't advise other people to do. I think something that I did that I wouldn't advise other people to do is that I would often start with the question, and then from an epidemiologic perspective, I would go and find a data set that could help me answer that specific question. I would answer the question, publish the paper, and then I would throw that data set away. I think that there's better opportunities to get really deep into one data set and answer a lot of questions rather than starting and being so fixed on the question that you end up picking up a different data set every time you do it.
So flexibility.
Flexibility, and also recognize the investment that you've put in to be able to put out that paper, and know that the next incremental paper, if you stay with where you started, is just so much lower than the activation energy of going to a whole new data set and starting from scratch.
And you're saying you learned that the hard way, I guess.
I just learned that after 5 years of doing that I have 5 papers, rather than after 5 years of doing that having 20 papers.
Yeah.
And I think that I diluted some of my experience.
Lastly, we were hoping that you would help us with our Research Ride playlist. So when we ride our bikes, we often listen to music, and we want to get what you would contribute to that playlist.
Oh man, that's one of those things that can I pull out my phone and
Sure,
look on Spotify?
sure.
So
this is an open book test.
Yeah. Okay, great. Just like the internal medicine boards, you can go on up to date.
That's right.
It takes a lot of time to go on up to date a lot. All right. So I'd have to give a shout out to Tom Petty. I'm a big Tom Petty fan, and Swingin' by Tom Petty. So I've been really fascinated by the song When the Levee Breaks, which you would know from Led Zeppelin. It's a Led Zeppelin song, but actually Led Zeppelin picked it up from a 1930 African-American blues singer.
I believe that artist is Memphis Minnie. The blues version is great.
I do like the blues version, and I actually like songs that are reconfigured, and so I like that song a lot. And then really high on Lake Street Dive. And I don't know if you've heard about Lake Street Dive. Yeah, I've heard of Lake Street Dive. So Lake Street Dive has a bunch of good songs out.
So you've got a real range here, right?
Yeah. I mean, come on, really. My wife and I had this bet that, we would have to at least go to a concert where someone wasn't putting out their first album in the 70s to try and keep it real. I also like Rafaela. If people are, she has a song called Buick that I think is really good.
Okay. Now I think finally.
All right, man.
I think so.
Thanks, Sarah.
Thank you for coming.
Thanks, Charlie.
Thank you, Ted.
Hey, I even went to the wrong library, and I made it back from there.
I hope you can make your talk with Bob here.
I'll tell him I was doing a podcast. He'll understand.
Yeah, he'll know.
All right, Ted Johnson out. At Baldhead Ted.
Thank you so much, Ted.
I know, it was a real pleasure.
Thank you so much for coming.
No, it was my pleasure.
Thanks for joining me on another great research ride. Our guest today was Dr. Ted Johnson. Producers of this podcast are Sarah McClellan and Ben Searles. Ben is also the editor of this podcast. Theme music composer is Hannah Searles. And I'd like to give special thanks to Dr. Melissa Stevens and Dr. Camille Vaughn for contributing research that went into this episode. This has been your ride leader, Charlie Searles, and I will see you next time.